I know it was, is everybody the cholesterol?
Yeah, one of them wasn't used, I don't remember which one it was now, but.
Oh, man, I didn't even know that, man, I just like,
There's some stuff on there from last quarter.
Yeah.
Yeah, that was saving that.
But before we go into chapter 3, there was one more thing on chapter 2 that I wanted to touch on. Let me go get my clicker. Actually, I don't have my clicker.
She said, you might have already walked out. Hope so.
Oh, I got my clicker. I'll tell you what page it's on. She says Miss McCullar, did anyone tell you that Julie said this next? She wanted a second. Okay.
She got a new phone, so she doesn't have numbers. Any of our numbers, so it's
She posted on Facebook.
okay. She's down on Facebook, so.
The patient bill of rights, y'all remember reading that? 66 and 67. We talked about them kind of in general, but probably not all of them. Page 66. This is that last little part we really need to get. I didn't test you on it. Just fair game after talk about it. Okay, so the patient bill of rights is kind of like, you know, the Bill of Rights of the Constitution, along the same kind of lines, the rights the patient has. And we're held accountable for them. Of course, they know that, or we know they should be treated with respect. They have, you know, control over what happens to them. They can decide, remember we talked about if they want it or if they don't, want the exam, any kind of treatment. So they can refuse treatment. They can obtain their own medical records. Now there's a, you know, you don't just hand them over and say, hey, I'm Jane Doe, and you give them all of Jane Doe stuff. Of course, they have to prove who they are. All right. They have the right to have their privacy protected. So a lot of departments, the patient may have access as far as seeing your logbook. A lot of the ultrasound departments are small. So you might have like one desk that has maybe all the orders on it. If it's any common area that a patient, whether you walk by that desk to take them to the exam room, all that has to be covered up. Any identifiable patient information. their name, their age, their address, their records like prior exams, anything like that, you have to have all that covered up, okay? They have a right to privacy. And that will kind of bleed over into the HIPAA stuff we're going to talk about too. Informed consent. When they give you their consent, we've got to make sure that they are lucid and they know what's going on, okay? If you're talking to them and you get the feeling that they're a little spacey, maybe, kind of like somebody that's been given medications for pain or something, they're real slow to respond. If you get a feeling that they might not really know what's going on, then that's not informed consent. They could say yes and really not know what's going on. So you would have to get whoever is with them, like the next of kin, or somebody has their power of attorney. You have to get informed consent from somebody that's sane or in their right mind. Not that they're crazy. You know what I'm saying? Somebody that's in their right mind, not under the influence of medication, stuff like that. Especially if it's an invasive procedure. Okay? Doing an ultrasound that somebody doesn't realize you're doing, you know, what you're really doing it for is one thing. But like doing an injection or a transvaginal ultrasound or anything like that, it's best to get written consent for you to do transvaginal if at all possible. Have a witness that you have their consent. Patients have the right to make their decisions about end-of-life care. They might not want to be resuscitated, okay? And that's, you know, DNR in the medical field means do not resuscitate. Here it means did not return. So if you hear us talking about DNRs, it's about the student didn't come back this quarter. When I first got here, I'm like, DNR? Why is that student DNR? Why do we need to know that they're DNR? Yeah, anyway, it was a little confusing for me. But anyway. Alrighty. Also, the patients must understand that they have a responsibility to maintain healthy habits, be respectful providers, be honest providers, comply with treatment plans, prepare for emergencies, all of that stuff. But they don't always do that. Okay. Patient Bill of Rights is really for their protection. Okay. Another part of it, this book really doesn't go that much into it, but think about it from a patient's perspective. Patients have the right to competent care. Okay. Have you ever thought or questioned when you go in for a procedure that they know what they're doing? You kind of assume that they hold that position. Most people do. They trust that you have that job because you know what you're doing. And that's where competency falls on us. We can't just pretend to know what we're doing. What I mean by that is, for instance, I've seen techs before do some things that are not very, they don't have a lot of integrity to their actions. In other words, I've seen a tech, they couldn't find the left kidney, so they just took a picture of the right twice and called it the left kidney. Okay? Didn't know how to find the pancreas, so they just put on every patient pancreas area. That's not competency. Okay? Patients have a right for, they expect and they should be getting somebody that knows what they're doing and somebody that has integrity. There's nothing wrong with owning up to the fact, hey, I can't find it, I didn't see it. And in our interpretation, the technical report that we do, you're going to say that. If you couldn't find it, say it. Okay? There's nothing wrong with that. Don't hedge around the subject. You know, you're not going to lose your job unless it's just an everyday thing you can't scan. You know what I'm saying? Right. Some people are harder to find. And if you need help, say, yeah, I really need you. I know you're great at finding the common ball. Can you give me some tips? Because I struggle with that. You know, get help. We try to, you know, give you all that here, but when you get to the real patient population, it's not like scanning healthy young adults. Okay? is a lot different. All right, so learn as much as you can here in clinical.
What would you do if you couldn't find something and there was somebody else to do?
And it was what?
And there was nobody else there to help you?
You would do the very, very best you could, and you would annotate what the difficulty was. If you were not available to, like there's some abbreviations y'all ever learn. Like, anybody know what this means? Within normal limits. Okay, a lot of people use that all the time. There's nothing wrong with using that, but before you put that on your impression sheet, you better make sure everything's within normal limits. Because if you say that and you didn't see, like say you couldn't evaluate the common bile duct or the pancreas, you better have that on there. Maybe list the difficulties first. Due to excessive bowel gas, pancreas unidentified, then extend it to but the liver, the kidneys, the gallbladder, all of your within normal limits or whatever. Does that make sense? If that's all you put on your report, then they're going to assume that everything you scanned looked normal to you. Okay, does that make sense? Okay. All right, the Health Insurance Portability and Accountability Act, HIPAA. Is very, very important to any healthcare professional because it's a federal law, a mandate that says the patient's privacy must be maintained. Okay? This is part of that when I said that if you have patients walking through the department, you will code the identifiable information. Just don't take any chances. Cover up everything, okay? You might have a patient log that's only the hospital-generated patient IDs. And, I mean, that, I guess, could be kept out because nobody knows whose number is whose, but still, I would just cover everything up just to make sure. Be very careful about when you're walking around, like say you and another tech are going to lunch, and oh, I saw this interesting breast case today, and you're just talking about it. You might not mention anybody's name, but it could be that maybe the patient's friend that came with them to the exam, they know that they had a right breast ultrasound, and you're talking and describing everything you saw and how bad it looked. They're going to be able to put two and two together and say, that's probably my friend that they just scanned right before they went to lunch. That's a violation of HIPAA, even though you didn't say a name. Does that kind of make sense? You can discuss things like that, but not in the public arena, like not in the elevator or walking down the hall. Like if you're in your department, there are no other patients there. Of course, you could share case study type scenarios because that's a learning experience, right? Look at this, look at this. And you show the pictures, you know, when I scanned it, this is what happened, and that's a learning thing. You just don't do it in public. Where Aunt Johnny that's walking behind can hear and know that that was Renee you're talking about. Okay? Especially don't say names, anything like that. And anything that does have identifiable patient information, like if you're destroying it, of course it has to be shredded. The HIPAA thing, like I said, it's a federal government, it's a whole law, it's an act. Any HIPAA violation can be punishable by really large fines, like $250,000 per occurrence, and up to 10 years imprisonment. Okay? I don't have that kind of pocket change, and I don't want to be locked up myself. So take it very seriously. But what it was supposed to do is to give the patients control over their information. Kind of like your social security number and your credit stuff, you know, you don't want that just given to anybody. They might have social security numbers and birth dates and names. If somebody could steal that information from a hospital, they could open up credit and they could do all kinds of stuff, right? So it's very, very important that you're familiar with HIPAA And they've got some links in here on page 67 that you can, you know, look up some stuff if you want to kind of learn a little bit more about it. So down at the bottom of page 66, and it carries over to 67, for sonographers, the HIPAA Act means the following. So it kind of goes over everything we just talked about. Having screensavers, because you'll be entering patient information into a computer and doing all that stuff. So you've got to be sure that that screen's not still up there when another patient walks through, right? So think about computers, phone conversations, anything like that, okay? Also, it goes into if the patient doesn't want a student to be present during the exam, then that's their right to say no. Okay, so be prepared for that when you're at clinical. The sonographer should introduce you. This is Jessica. She's our ultrasound student. She's going to be observing if that'll be okay, or she's going to scan you if that's okay with you. Really don't just say she's going to be observing, because that's kind of an order, right? They might not know that they have the option. They should be saying if it's okay with you. All right? Any questions about HIPAA or patient bill of rights? We didn't get to touch on that. Actually, that is in the back of 3, isn't it? Well, I'm a silly willy. I could have sworn that I was supposed to have talked about that too. Okay, we'll go back to the front 3 now.
Do you have a?
Oh yeah, I do. I beat myself up last week. I was like, shoot, I didn't get to any of the HIPAA stuff or patient bill of rights stuff. And it
I
was
was
back.
looking at the back of 3, I thought we were going on that.
Well, I just now noticed that it said 3, but I was telling myself all week last week that it was the back of chapter 2 and we didn't get to go over it. So here's one thing. It's like a ghost. I don't see it till I'm right on top of it. I don't know why. That one's supposed to be 2. I beat myself up for nothing. I tried it in a different format, since y'all weren't really taking so many notes beside it, to save a little paper. I don't know. I probably saw that because somebody was sitting there. I'm sorry, is it too bad?
Well, the lady in the
I tried
library showed
something
me
new.
how to print these out. Like, I printed out the 2,
No, on the
the
very
last
front.
one, and just outline form,
Oh,
like
cool.
that.
So if it's on the portal, you can get it to an outline form?
Yeah,
Oh,
you can print it out just in an outline if you'd rather. And, it'll take like 4 sheets of paper.
Well, maybe I need to
Front,
take
back,
care,
or whatever.
can you teach me how, maybe, and I can start doing that instead of that?
I can try and only do it once, but,
have the pictures and all that on.
Huh?
yeah.
It doesn't?
I don't know, I'm not sure. Because I don't think we had pictures in, 2, did we? No, but it might, I'm not positive. But anyway, that's a possibility if y'all want to do that.
Okay.
Sorry.
No, that's great. Thank you. I had to get Miss Bandit to show me how to clean that off. Alrighty. Nothing else? There we go, now it should work. Okay, so essentials of patient care. Part of this physics registry that y'all be taking for 7 encompasses patient care. Okay, but you'll have a couple of quarters of clinical behind your belt, under your belt before you go and take that exam. Because this stuff will make a whole lot more sense when you see patient care. Does anybody in here have experience with patient care? Okay, so it's okay if you don't, but you know, that'll help y'all. All right. I know I was scared to death when I first got into this career, because you go into, say, an ICU, intensive care unit, and you see all these tubes and plugs and beeping things, and you're like, maybe they're intubated, they have a breathing tube down their throat, And you're like, well, that means they can't, I mean, I wasn't so dumb, I was like, does that mean they can't breathe on their own? So if I extubate them, accidentally knock that out, because I don't know how to put it back in, I can't put it back in, not legally can't put it back in, so. That case, especially with babies, infant, scared me to death, because, I mean, think about it, how tiny a baby is, the distance from their little mouth to their lungs, not very, it would take much to knock that out. I'm scared to death around here. But anyway, then you get used to it. You learn what you can touch, what you can't touch. Like a dialysis machine, don't ever get near them. Just don't even just avoid them. Come back and do that patient later if they're doing their dialysis. You can mess those up, so I've heard. You know, I've just avoided them like the plague. Dialysis nurses are usually, you know, pretty quick to tell you don't get near my machine. There's a reason, I don't know why, but I just know that it can be very bad if you bump it or mess it up, okay? But while the patient is in our care, so they come down to our department, an inpatient or even an outpatient that walks in on their own, y'all know what that's called? That they can walk in on their own power? Ambulatory, okay? And to me, when I first heard that word, I thought ambulatory, ambulance. I think somebody on ambulance couldn't walk on their own. Anyway, don't think that. Ambulatory means they were able to walk their own power into your department. You didn't have to have a wheelchair or a stretcher. Okay? Oh, that's amazing. So, whether they're inpatients or outpatients, when they're in the ultrasound department, we're the ones that are supposed to be giving them care. Now, the care we give is just to the level of our training. We don't pretend to be nurses or anything like that. For instance, y'all know what an IV is, right? Intravenous fluids or medicines that are being given. Well, has anybody in here not had an IV before? You've never had one? They're not fun at all. It hurts, pretty much, to get one. So you don't want to get another one, right? So we have to keep an eye out. So they come down with just a bag of fluid. We want to make sure that that fluid bag's not emptied out while they're there. Because when it empties, there's a certain amount of time that blood will start backing up. And if it clots off in there really bad, they won't be able to use that one again. They'll have to get a new IV. So we have to pay attention. So now, are we going to change the IV? No. Are we going to flush it out? No. We're going to pick up the phone and call the nurse, right? And let them know, hey, Mr. Smith's IV bag is, you know, right at empty. Y'all might want to come check it because he's going to be down here for at least 30 more minutes. And I say, oh, it'll be fine. Or they might come, I don't know. It's up to, you passed it on to the nurse. It's up to them, okay? Maybe the patient is nauseous, okay? And they throw up while they're down there. Guess who gets to clean it up? The sonographer, okay? Maybe they are in the middle of having a miscarriage and they're bleeding like a stuck pig, okay? Blood everywhere. And guess who gets to clean that up? Whatever happens in your department while they're there is your responsibility, okay? I try to think of it like when that patient's in the room, they're my relative, okay? They're like my mom or my uncle or, you know, whatever the age range is, you know. And you have to take care of them accordingly, all right? Now, you have to kind of evaluate your own self emotionally. There are some people that have no business being in healthcare. What I mean by that is some people have zero compassion, like my husband. No, he could not do it. Now, if I'm ever deathly ill, y'all gonna have to let somebody know to take, because he'll let me just lay there. Okay? He can't deal with it. I'm serious. People like that do not need to be in healthcare, but some of them are. Okay? Hopefully, you're this deep into the program, you have a compassionate bone in your body. Some people don't even have one. But if you go about treating patients like they are your relatives, people you like, the relatives you care for, okay? I know we all have those, but the relatives you really, really like and care for, then everybody's going to pretty much give good patient care. Does that make sense? If you think about it, I got a gallbladder patient from the ER and then they're going to be puking everywhere. They're probably not going to get the best of care, okay? Be prepared. If you know that that gallbladder patient's coming, that most of the time they're going to be very nauseous, they might be throwing up, and you need to have something ready for them to throw up in. You know, be prepared, and that'll help with some of that.
I read in here somewhere that like if they do throw up or whatever, like you should throw it out. You should save it for the doctor and nurse to look at or something.
That might be something that is a protocol for your facility. Maybe we need to find out when we go if that's their protocol. I was never told to do that. I never did it. But it would probably be up to that facility. If they're coming from the ER, they've probably been thrown up in there too. But maybe it's an inpatient. That brings up a good question. I never really thought about it. You might have to say, you know, is this a new symptom that you're having? Maybe if it's something new, then you might want to call the nurse and say, hey, Mr. So-and-so has started throwing up. Is this something y'all need to look at? That's a good point to bring up. I never really thought about it.
I know my son was 13. All the blood drained down his back, made me stick my stomach, and
Yeah.
I threw up. And of course, I haven't let him flush the toilet.
Yeah.
I told my dad, I just threw up. And he told the nurse, and she's like, did she flush it? Did she flush it? So
Okay.
she wanted to see what.
So that was a new symptom.
Or,
Yeah.
you know, anyway.
Right. That's a good point. I never really thought about that. But you can almost guarantee somebody is going to, especially because if you work in a radiology department, you're going to have a lot of people coming from the ER with gallbladder trouble. Okay? Now, there are things that we just have to observe and notice as well. I mean, that would be, you know somebody's throwing up, you're going to know that. But sometimes people have things going on that are not as obvious. So you got to keep your eyes and ears open too. And don't be so focused on the screen that you don't realize your patient stopped breathing. That kind of thing. You know, you got to be, I had that happen, they didn't stop breathing like their dad stopped breathing, but it happened to me the very first time I remember it happening. The man had sleep apnea. And so he stopped breathing while I was scanning because he got really comfortable and just went to sleep. You know, how we're teaching y'all to watch respiration. So I'm scanning and all of a sudden his organs stop moving. I'm like, and I'm watching. I looked up his heart real quick. His heart was beating. So I'm like, phew. I'm like, Mr. So-and-so. That freaked me out for a second. I'm like, I don't know. I was like, what's that phone number I gotta call? There's like a little 4-digit code you gotta call and tell them to blue where you're at. I told my neighbor in McMahon, I'm like, look, I'm probably gonna forget that if it ever happens, at least the first time. So I'll just stick my head out the door and go, oh, blue! Yeah, just come on. Come on. Luckily, thanks to the Lord, that never happened. That was my biggest fear. Somebody would, their heart would stop beating while I had them, you know. Anyway, so, this chapter starts off talking about our obligations. I guess I need to advance the slide. Okay, we talked about this a little bit before. Of course, our patients are our customers. The people reading the exam they're our customers. We have obligations to be professional so that our profession will be well represented, and then also to ourselves, being professional is going to, you know, help us as well. Patient-focused care. Again, you've got to remember the patients are why we're there, and hopefully you got that compassionate bone in your body. If you see the patient's cold, give them a blanket. And again, I can't reinforce this enough. You're going to hear me say it over and over again. So I'm just going to keep saying it. If somebody's upset about something, what are we going to do? We're going to let them know that we hear them, okay? You're not just gonna, he's complaining again. Okay? Even if you know that the patient's perfectly fine, there's really nothing wrong, if they have a complaint, they're gonna get agitated if you don't respond, right? To diffuse the situation, you respectfully, don't talk down to them like, you again, that kind of, don't talk down to them, just let them know, Mr. Smith, whoever it is, I understand you're tired of waiting, let me go ahead and call transportation again, and, say he's an inpatient, somebody's waiting to go back to their room, your exam's over with, sometimes transport is slammed, okay? You might just have to, if it's gonna work with your schedule, if you don't have like the ER calling, there's not another static exam, you might just have to take the patient back yourself, right? But don't just let them sit there and moan and groan and call for help and not address it, okay? Sometimes if you explain to them, I call transportation and they're a little bit behind right now. If they don't show up in the next few minutes, I'll just take you back myself. And that'll calm them down, Just give them an explanation. Think about what you would want to have happen. That kind of thing. Okay, these are those observable and measurable signs of life I was telling you about. Some of them that, not as obvious, like I said, is throwing up. You want to make sure, of course, the patient's breathing, but then you need to know what is the normal respiratory rate. If you look on page 37 of box 3-1, it tells you for the adult, the adolescent, school-age child, preschool child, or 1-year-old newborn. All of these things, the pulse, respiratory temperature, and blood pressure, the normal ranges. So for an adult, normal pulse 60 to 100, look down like a 1-year-old or a newborn, 120 to 160. So there is a big difference, okay? If you have an adult that has a heart rate of 160 beats a minute, that's approaching tachycardia. There could be something major going on. It could just be something as simple as they're dehydrated, or their heart's having to pump harder because, being dehydrated, the blood's thicker, you never know. But we need to pay attention. Maybe the patient comes in and they have color in their face, unlike maybe that, I didn't wear makeup, sorry. But they, a normal color, and then as you're scanning them, which is kind of hard to see in a dark room, if they get kind of ashen, the color washes away, they start sweating, they get clammy. It could be something as simple as a vasovagal reaction. Maybe they just had a procedure like somebody stuck them with a needle or something, and it's something they can recover from. Or it could be that they're starting to have a heart attack. We got to notice stuff like that. Got to pay attention. Okay. Blood pressure. I'm going to work with hopefully Wednesday if I can get some MA students to come in and help us learn blood pressures. If there's any available, if not, we'll just work on it together. Maybe Ms. Prim can help us. We'll be doing that in labs on Wednesday. Okay. But taking blood pressures, luckily a lot of departments have the automatic machines now.
This Wednesday? We don't do blood pressure? Okay.
Yeah, hopefully if I can get it worked out. But a lot of departments have the automatic one, or the, like the electronic kind. You stick the patient's arm and line up the cuff properly and tighten it properly. You hit a button and it does it all for you. But we're going to learn the manual way. They have one of those as well, so we'll show it to you, but we're going to learn the manual.
So are we going to be required to get a set?
No. 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 See, the good thing about with ultrasound, you can take somebody's heart rate with the machine. That's subxiphoid, just point it up, do a pulse wave or an M mode, and it'll tally up the heart rate right there for you. So we're kind of good with that. And again, if you're going to take blood pressures, then they'll probably have that automatic one, or maybe there'll be like one stethoscope and one cuff in your department. So you won't have to be like a nurse, because nurses pretty much, they want to use their own, they use them so much. They carry their own around, I think, But it'll be few and far in between that y'all have to do them. For instance, I never did them at the hospital I worked at. If there was somebody that needed it, we had a nurse in radiology. That's all she did was work in radiology. Now, she mainly stayed in special procedures. One of them did, and the other one, she stayed over in the MRI or CAT scan suite because they give them that dye contrast. And sometimes it can put people in renal failure and stuff, so I guess that's why she couldn't stay up there. But we just paged one of those 2 nurses and they came over and did whatever. So it'll depend on where you work, but we're still going to learn how to do it. Okay. We'll practice taking a pulse this way too, but if you've got your machine, do it that way. Okay. Their temperature. Now, some people, you expect them to have a temperature. Like, say, if a patient comes in and the doctor suspects that they have a pelvic infection, and that's what they're wanting you to look for, is signs of abscess or infection, they're going to be febrile. More than likely, febrile, they're going to have a fever. So, I guess it would be something like you noticed they were normal temperature when they got here, now they're burning up. You would let them know, and they'll let the nurse know. What did I do? Uh-oh. I don't know what I did. Okay. When you're doing the heart rate, you also want to listen for irregularities. Now, I don't know, if you're taking somebody's pulse, a lot of times people just count it for 15, maybe 30 seconds and then double it to get the beats per minute. I don't know that you're going to notice that much. You're not going to sit there and take it that long, typically in an ultrasound department. But like if you notice it speeding up, slowing down, speeding up, slowing down, you know, that would be an observable that you could let them know, that kind of thing. Okay, tachycardia is when the beats per minute are elevated too fast. Bradycardia is when they're too slow. And it'll tell you the normal pulse rate again, which means 60 and 100 for an adult. All right. Bradycardia, if you look on page 38. Okay. Fewer than 60 is Brady. And then over 100 will be tachycardia. Respiration. Okay. If someone is breathing too much, like if their breathing is very, they're upset and nervous and scared to death, they can actually hyperventilate. They can get too much oxygen. So you'll want to calm them down. Andrew, you okay? I know it's boring, I'm sorry. You've seen on movies and stuff where they give them the paper sack to have them breathe in and out. That's to limit their oxygen intake so they're not hyperventilating anymore. Okay? It restricts the flow of oxygen to get that oxygen level back down. You can have too much. Okay? So that hyper's not enough. You know, if somebody's respiration slow down a whole lot, they might be, like their organs might be failing. That's a sign you definitely want to me, that's almost scarier than the hyperventilation. I'm not a nurse, but, you know, the only people I've ever encountered that the respiration really slows down are like my relatives that have passed, you know, like right before they die, their respiration just really, really slows down. I guess that's why, for me, that's why it's more scary. So, pulse oximetry. You've been to the doctor where they put the little clip on the end of your finger. They can measure the oxygen levels in your blood that way. You know, that's something they can do to check it out. Our respiratory department, they have little breathing tests that they can do. They had a health fair one time, and I learned I need to do some lung exercises because you have to blow for as hard as long as you can into this little tube just to see if your lungs are adequate. And mine did not pass the test. I don't know if it's allergy season or what, but so anyway, normal reading for a person in breathing room air is the high 90s. 90 or less of that oximetry, they, are going to put the patient on oxygen probably. But even a little fluctuation in it, just a personal observation. I've gone in with bronchitis before, and it'd be like 98, and I didn't think that was bad, but the doctor's like, you might be fixing to get pneumonia just by that. So, I guess it's very sensitive. Okay. Another thing, if you look on page 40, okay, if you look at the the rhythm, if they're breathing regular, in and out of their chest, how much is the depth of their respiration? Like I said, they're going, that's not really deep breathing. That's not good. Is it labored breathing? Are they wheezing when they breathe? That kind of thing. I know sometimes you'll go to the ICU and they will be ventilated. They've got the ventilator tube down their throat, and you'll hear a gurgly sound, and you can tell they're having a hard time, and they might be trying to cough, but you can't really cough with that tube down your throat. So you need to let the nurse know, because they have to do like a suction thing. There'll be like phlegm and stuff in there, and that's about the only thing, well, that and certain smells, that kind of bothered me. I didn't like the suction thing because it makes the patient gag, and they're like, again, they're trying to cough, and you hear all that junk being pulled out, but they got to do it because they're kind of choking on their own phlegm. So that's an observable. If you're in a unit, you'd say, I think Mr. So-and-so or Miss, I don't like those men, I'm referring to, Miss So-and-so might need to be suctioned. They're having a hard time. We need to let them know that, because they're going to be coming around, but would you want to lay there and choke? I wouldn't. So that's something else we can do. Okay. Any difficulty in breathing, dyspnea, or changes in their color, cyanosis, is also something. Like if they're saying it hurts to breathe, or if they start turning blue, that's cyanosis. The painful breathing, the only time I really experienced that, some patients have an excessive fluid around their lungs in the pleural space, not in their lungs like pneumonia, but just like in the sac the lungs sit in, and that is hard for them to breathe. So they'll come to ultrasound. Sometimes they have a thoracentesis, and that's where they drain that fluid from around their lungs. And we'll scan them from back here, away from the spleen or liver, away from midline, and we'll look for fluid pockets. And part of our job is to say it looks like thin fluid. Thick fluid would have debris in it, wouldn't be anechoic. Does that make sense? Okay. And even if it does have some debris, if you get the patient to talk or cough, sometimes that debris will spin around. If it moves freely in there, they could probably do a thoracentesis, but if it doesn't move or swirl around at all, the patient's probably going to have what they call a chest tube, which is a lot more invasive. It's a lot harder procedure. That they go to the OR, I believe, for the chest tube. I'm not real sure. They don't do it in ultrasound. Okay? Chest tubes are a bigger thing. But with thoracentesis, we measure the pocket of fluid, put an X on the spot the needle needs to go in, and they go in and drain that off. And during the process, when the fluid gets to the point where the lungs start expanding again, the patient will start coughing a lot. So as far as dyspnea, that's about the only thing I can think of that you'll experience. Okay? Now, if they're turning blue, I never have seen anybody turn blue. Now, I've seen newborns that kind of have a blue tint to them. Maybe the holes in their heart haven't closed up completely yet, or they're in respiratory distress. But they'll be in the NICU, in the neonatal intensive care unit. I've never really seen any blue there either, but cyanosis is something they look for after they're born. I hope I never see anybody that's blue. Apnea is when their respiration stops, like that man I told you I was scanning, and he just went to sleep. So, do like I did, look at his heart real quick, make sure the heart's still beating, and then just wake him up. So, okay. If you're going to count respirations, of course, it's a number of inhalations. And since we got a probe, it's so much easier to watch that rise and fall. You know. Okay. I've already talked about that. Blood pressures. Okay. So the pressure by blood going, flowing against the blood vessel walls is what blood pressure is. Systolic is the high number when the heart is contracting. Diastolic is when it's not contracting. Okay? So it would be the lower of the two numbers. Systolic's on top. Like mine's usually 120 over 70 or so. And unless the first pregnancy I had, here's what somebody that might come in with high blood pressure. Some patients can have a condition where their blood pressure goes up during pregnancy. Okay, and it can get pretty high. It can cause strokes sometimes if it gets to the worst case scenario, coma. It used to be called toxemia. Now they call it, preeclampsia if the blood pressure's just going up. If it turns into the stroke or coma, it's eclampsia.
That's what I had. It was like, my blood pressure was like 130 over 136 over 110.
Yeah, it can get pretty bad. Okay, hypertension. Usually, people have hypertension, they're at a higher risk of arterial disease, of heart disease, a lot of health problems. So they try to keep their blood pressure down. Their heart's pumping harder when there's more pressure there, so it's a strain on the heart. Some people have the top number up to 140, or the bottom number, the diastolic, remains at 90 or above. I don't take blood pressures often, but just from what I've heard, that bottom number is the more concerning number. Okay, because you could have like a 120 on top, but if that bottom number is like in the 90s, 90 or above, they consider that still high blood pressure. Whereas if it was just the top number that was high and the bottom number that wasn't, it's not as worrisome.
The closer the numbers are together,
The better they are,
no,
the worse they are. I did it again. They should put that okay. Okay, is that all I said about that? Gosh, there's a lot more here. Hypertension. Hypotension is an abnormally low blood pressure. 90 over 60. Again, the only experience I've had with that, again, is the relatives I've been with that have passed. Like I said, the respiration slows down, and then that blood pressure bottoms out. My aunt had leukemia, and her bottom number was 40. That's the only one I remember. I don't remember what the top one is, but in my heart, I'm like, I don't think we can recover from that, but we knew she was going. And she would take a deep breath and not breathe for a long time, and then it was like, it felt like 10 breaths a minute. It was like, anyway, that's the only experience I've had with the hypotension. Alrighty. We'll chug along through. I did it. Okay, patient needs. This is the stuff I said have ready for them, except for like the nasogastric suction tubing, urinary catheter, nasal catheter. We're not going to have all that stuff, okay? But that would be, like, if you notice, like the IV is getting low, or if maybe you've already noticed the blood backing up, stop right then and call. Okay, you're not going to have anybody transported that's on a ventilator. Okay, they can't be transported down to you. You would go to them, but they might have oxygen. We talked about that. You look at the number. Go ahead and turn it on the wall, and move the patient to the part that's turned on, and then turn the tank off. Because I can't tell you how many times I've done it the opposite way, and squirrel. I'm like, shoot, what number were they on? I had to call the nurse and say, and this is bad, but yeah, I can't tell you. It only happened a couple of times, and I'm like, put it on the wall first, then turn it on. So, Because oxygen is an order, it's like a drug. You can't just decide what you want to be on. You gotta follow the doctor's order. Anyway, the cannula will come with them. That's the little thingies that go in their nose, the tubing. Okay. All right, wounds, again. We're not going to change anybody's dressings or anything, but you might have to scan a wound. Okay, it's like we're not going to do all the wound checks. Like the nurses have to check it, they'll date with the dressing and do all that stuff. I think they even have to check for odor and stuff like that. But be very careful around dressings. If you have to scan a wound, always use the little sterile gel packs. You don't want to introduce any more germs than, I always would cover the probe. You don't have to have a probe cover. Those are really pretty expensive. You use them just for the OR or a special procedure. It's got to be sterile. But you can put a sterile glove over it, not touch it. You put gel on the probe, put the sterile glove over it, and then put gel on that and scan with that, and that'll kind of eliminate some of the germs. So, just be very careful. And I would just tell the nurse, they know that you're scanning it, but I just give them a call and say, hey, I didn't really take the sterile gel off. I'm going to let you deal with that, because I just get the heebie-jeebies wiping anybody's open wound, Just use minimal gel and let them do what they need to do. Okay, that's really not what all the pumps look like. There's one in the nursing lab we can go in and look at. Y'all seen the IV poles and stuff like that? Okay. That's what figure 3.8 is supposed to, I think, mimic. Anyway, be sure to plug those up when they come to your department, because they are running on battery. So as soon as the patient gets there, if they have an IV pump, plug it up to the wall, because you don't want the battery going out on the way back to the room, that kind of thing. Catheters, urinary catheters. Well, I'll skip nasosuction too, excuse me. If you look in figure 3-9B, there's a man with a nasogastric tube, and that's going straight into his stomach.
The doctor there said tomorrow and we didn't get the fix. Do you have a problem with that?
What time?
You'll come 12.
No.
Okay.
That's perfect.
All right.
Okay. There's a, y'all are welcome to come if you can. He's a radiologist. He's going to come give a talk. I don't really know what. It's probably on musculoskeletal if y'all want to come at 12. We didn't know until just now. We knew he was going to come, not we. Okay. The nasogastric tubes, just don't ever pull on that tube, okay? Be careful of any tubes, but anything going in the nose or the mouth, be very careful, because we can't put them back in. We can't put IVs back in either. Just don't, or catheters, Lord have mercy, don't pull that out. There's a balloon on the end of it, okay? So just be very careful. And don't assume, here's a word to the wise, okay? Most people that are transporting a patient will put the catheter bag, the urinary catheter bag, like hanging on the side of the wheelchair or the stretcher. But some patients are really weird about that, and they want it in their lap because they don't want people seeing their urine going down the hall or something. So you got to be very careful. Don't just pick the blanket up and take it off of them, because there might be a catheter under there. Okay? You don't want to pull on it. If you look at figure 310, did anyone here not have a catheter? They're horrible. They're awful. Okay? If you look at that figure 310, there's a tube with a bag on one end. The other end goes through, this is a female, of course, patient, but it would be the same for a male, goes through the urethra into the urinary bladder. And it looks tiny. If you would blow this picture up, see where it says balloon? Okay, so the urethra opening, teeny tiny. Once it passes into the urinary bladder, the nurse will fill that balloon up so that it can't slide back out. But there have been patients that have ripped those catheters out with that balloon. It's called a Foley catheter, and we can see the balloon. Like when we scan that fully descended urinary bladder. Okay, now, when you have a patient, this will be the last thing we probably get to talk about, but if you have a patient that comes to you from the emergency room and they want us to do a pelvic exam, most patients, when they're coming to the emergency room, they won't let them drink anything or eat anything until they figure out what's going on, because if they had to go to surgery, then it would be delayed. If it's an emergent situation, you see, so they don't let them drink anything. Okay, I'm going to spill a pet peeve of mine out. Inevitably, the patient has a full bladder. They put a catheter in it so I can fill their bladder. I wish they would just say, do you feel like you have to pee? And let me just look at it. But the nurses just stick that catheter right in. But anyway, so they'll get to me and they have a full bag of urine. I'm like, really? So, they've got that Foley catheter in there. And the whole point of a catheter is to drain the urine from the urinary bladder. Well, the tip of the Foley is firm. It's not like hard as a rock, but it's really firm. And sometimes it'll irritate the wall of the bladder. Okay, even when you fill the bladder up, because you'll detach the bag and put fluid in, clamp it off to fill their bladder up so you can scan them, like repro. Okay? Pay attention to the patient. I can't tell you how many of them will tell me, this really hurt me, really hurt me. And if you look with the ultrasound, the tip of that Foley might be just up against their bladder wall or something. And you let them know you're going to do it, but you can push it in or pull it out, depending on, you'll be able to see how much slack you have. Reposition it just a little bit and alleviate. Because like, think about it, even when your bladder's full, if they have that sucker fished in there a lot, where it's cool, you know, poking, if you back it off a little bit. Or if the Foley's pulled all the way up to the orifice where the urethra starts coming, that can be uncomfortable. So you can adjust it a little bit and it just eases some of the discomfort. Now, they're going to have discomfort because it's there. But you know what I'm saying? Pay attention to your patient. And anyway, but be very careful. See how it's taped to the leg? They don't always come taped. And any movement of that tube, like you're moving them into the bed, it hurts. So if they're taped, it's not quite as bad, but still be careful pulling on that bag and tube, moving it around. Okay? Alrighty. The oxygen therapy is next. If the one thing I haven't told you about yet, I'll go ahead and just cover it because I've talked about it a little bit. If they have an oxygen tank, everybody know what I'm talking about? What an oxygen tank looks like? And I don't know, it's been a long time since I've been in the hospital. They might not even carry around those gigantic tanks anymore. But think of it as a potential bomb. Okay? You cannot let it fall to the floor. Alright, because it's under very heavy pressure. You can't, not that you're going to take a patient to MRI, but I mean, the oxygen tank cannot go near the magnet of the MRI. Alright? You got to be very careful. Don't ever just lay an oxygen tank on somebody's stretcher with them. There's a special contraption to hold that oxygen tank. You got to be very careful with it. I just, like I said, I always told myself this is a bomb, and that'll make you be gentle with it. And they're very heavy too if they use the big ones. Now they might transport patients with, I've seen people are on oxygen, like on home oxygen, and they have these little backpack things like they carry. They might use those now. I don't know. We could ask the respiratory people. Those weren't around when I worked in the hospital. Well, because I never saw them. Anyway, people roll their little tank around, But just be very careful with it as far as that aspect of it. It'll have a meter on it to control that flow. And it is kind of neat. We can look in the nursing lab, and we'll take a tour of the nursing lab because they've got all this stuff simulated in there. But at figure 311 on page 46, a lot of them are like that. They'll have that little ball that floats. And you just put the ball turn it up till it floats with the number that was ordered for that patient. They're not all like that, but that's a typical one. Okay. Sometimes if a patient is on oxygen, they'll want to get it off, and they'll constantly be taking it off. And maybe don't be ugly to them, but just remind them, no, I'll use Mrs. Smith, the doctor wants you to have the oxygen because you need it to start feeling better. You're going to have to keep that on. Just remind them, because they'll want to pull that because it irritates their nose, and they'll want to constantly pull it off. Okay? Especially if they're kind of out of their head. So be very careful with keeping an eye on that. Now the kind that goes over their mouth, I've seen patients take it and just scoot it over their chin to make you think they got it on. And you have to keep pushing it back up, and they'll scoot it back down, push it back up. So just keep an eye on it, because again, it's a prescribed drug. Okay, and it's ordered by the doctor, so he wouldn't have ordered it, or she wouldn't have ordered it if the patient didn't need it. All right. Alrighty. We'll start. We talked about wounds and stuff. Be sure your hands are clean. We talked about the gloves, aerogel. So we'll start with ostomy. Yeah, those are nasty, but we don't have to have them. Page 48, we'll start on ostomy next time. We'll actually do removing the patient and stuff like that in the lab.